So at this point, I am going to give it back to Dr. Badros, who can give us a real life example of what it is to try and change the course of multiple myeloma, some of the work and the effort that he is doing in Baltimore, in the area there. So Dr. Badros, we'll have you clip on your video and come back and join us as we think through a little bit about what you've done in your area and region to assist in the work of myeloma. So we'll turn it over to you, my friend.
So when I got the title of this talk, I really didn't know what you guys wanted me to talk about. So I just will go through some somehow. Oh, okay. Just as we heard, myeloma is a rare cancer, and it's more common in Black communities. Baltimore is 70% Black patients. I just have to stop here and say that I'm using the word Black instead of African American, and that was by the direction of many of my patients that don't like the term African American. So I don't know, maybe the Black African American community accept that both of them are interchangeable. And I would like to hear the opinion of people that will talk after me on that. Definitely, there is very serious health disparities in multiple myeloma, not just between white and Black, but between people that have access to centers and those who do not, people that have health insurance and those who do not. And I think these disparities are very clear in Baltimore, not just for racial disparity, but for socioeconomic disparity as well. I think one of the first things that I think of when I think of disparity, especially with Black patients, and I talk to them a lot, and I have many dear friends in that community, is the stigma of the disease. I was quite surprised to know that a lot of my patients do not share with their family members that they have myeloma. Some of them never say cancer. Some of them never mention the word cancer because they call it the disease. And I think open conversations will let us know that there is a disease called multiple myeloma out there, and your family and friends need to know about it. And more importantly, there is a lot that can be done about it. And I think this is probably the best way to educate our immediate community. I just have to say that I don't usually give this kind of philosophical talks. So I jotted some of my thoughts when I was trying to understand what is the myeloma in Baltimore is. So these are not very organized slides by any means. It's just my thoughts about the topic. I think we heard about empower our patients. The first thing that comes to my mind when I deal with any patient is to communicate with them honestly and to provide options. I think most of the patients on this call, if they're mine, I know that. Even if it's high risk, even if it's bad, if it's good, I always try to be as clear as I can be. And the end result of that, a lot of patients do trust us, trust me, trust our institution. And I think trust is probably the first step to empower you to make decisions. If there is no trust, and I can see it in many eyes of my patients, a patient look at me and say, okay, we will do this, but I know that the first minute this patient relapses, he's going to go to a second opinion in some of the other institutions around us. And if you lose trust in your physician, you probably should go to somewhere else, because if you don't trust what options he's giving you, you probably will not benefit from whatever will be discussed. So I think trust is crucial and important. I also think our patients need to be empowered by understanding what is going on. I have some of my patients with me for 15 years, and some of them summarized it very well to me. He said, you guys change your minds every 5-6 years, which is absolutely true. Why? We have new treatments. Treatment options are changing. What we consider standard of care today probably will not be the standard of care in a couple of years. We change the response criteria. I remember very well when a patient, I used to call him near CR, near complete response, meaning trace protein in the blood and zero. And then all of a sudden I changed it to VGPR. And the guy looks at me and said, what happened? Did I relapse? What VGPR has become the new definition of response. As new treatments come along, response criteria changes. The same with risk assessment. 15 years ago, deletion 13 was considered a high risk. Today, we know deletion 13 is present in every myeloma patient if you look hard enough. So deletion 17 is a bad risk today. Maybe with the introduction of CAR T cells, we will be able to control patients with deletion 13. We started to see the translocation 414 risk diminish significantly when we introduced the bortezomib or Velcade and Kyprolis. Disease monitoring, someone asked about MRD, it's changing. Are we going to be doing MRD for everybody soon? Yes, probably soon we will. At this point, we don't. Someone asked about liquid bone marrow biopsies. Yes, it's in clinical trials. You can get a small sample of blood and see if there is any plasma cells, and that can correlate with the plasma cells in the bone marrow. PET scan, which replaced the skeletal survey. So empowering patients to understand what we are doing and why we are doing it, I think, is crucial. Access to treatment is a huge issue, and I think it's important in cancer care in general. I think every patient should have the right to receive optimal treatment. We talked about diversity in clinical trials. I'm understanding very well the Black community does not trust the medical institutions. I think that cannot be said more than in Baltimore for many reasons, not to get into it. But I think that trust needs to be overcome, especially in this time. We heard about clinical trials. Most of the randomized trials in myeloma have less than 5% African-American or Black presentation, or minority, even Hispanic is lower than Blacks. And I'm proud, actually, to say that in our center, at least 30% of patients on clinical trials are minority patients, including African-American and Hispanics. Clinical trials are life-saving, and I wouldn't say no every time. I have to say that sometimes I mention clinical trials and the patient will leave me, will not come again, and because they think I'm going to be using them as experiments. And I know I was supposed to talk about my work, but I really don't want to dwell on that. But we have done several studies showing that if Black patients receive the same treatment as white patients, they have better outcome. And this was a trial done on transplants. We looked at our transplanted patients. They do better. We know that the African Americans are usually younger. They have favorable biology, meaning they don't have deletion 17. I think Dr. McHale mentioned some of that stuff, which is all published. And I don't want to burden you with that. Multiple publications have shown the same concept. Unfortunately, what's missing in our center is reaching the African Americans that are Black patients that do not come to our center. We know what happens when you come to us. You will get excellent care. But if you don't come to us, it's very difficult to provide that. I just want to finish my talk by a patient of mine, and I don't know if he's on call or not. I tried to call him yesterday. This is a publication that I have done, and I'm updating it today because it really summarizes what African-American or Black patients go through. This is a patient who presented at age 29. And Dr. Mikhail mentioned they have delay in diagnosis. Can you imagine a 29-year-old going to the emergency room saying, I have back pain? You know what they told him? He's seeking drugs. That's not just Black or white. You know, if you're white and you go to the emergency room at age 29, the first thing is seeking drugs. This guy presented with myeloma after about 6 months. He ended up compression fracture, lifting weights, and he got standard treatment. If you look at the beginning, when he presented, his IgG level was close to 10,000. That's as high as it gets in myeloma. He received Cyborg-D for 6 cycles, really no response. He came down to 8,000. He came to see me. At that time, we had a trial for VRD, the DVT pace. We gave him DVT pace treatment, 2 cycles, went to 7,000. This guy is not responding. You like to see 50% response, as you heard from Dr. Mikhail. So I did a transplant. And very quickly, by the way, you get DVT pace. Within 1 month, he's going up again. We did 2 transplants on him. Why? Because the first transplant gave him a little bit of a response, so I did a second transplant. His best response at that time was about 3,000 IgG. That's a very high level, but there was nothing else to do at that time. So we put him on lenalidomide maintenance. And you can see over the years, he started progressing. We gave him pomalidomide and dex, had a little bit of response. Again, IgG level always maintained in the very high. He went on a clinical trial with aprocimab, which is a a drug currently not in trial, had a minimal response, progressed. At that time, carfilzomib, Cytoxan, Dex were available, went on a clinical trial with that, had a nice response, started progressing. We added benabenostat, which you heard about, was approved at that time, stayed in remission for a while, went in the community and there was progression here. So we started him on daratumumab, Revlimid and Dex, because I didn't have any other options. Had a nice response, but then started progressing. Went on belantamab clinical trial, ubrudomide clinical trial, selinexor KBD clinical trial, and just transient responses. And you see, every time you get a treatment, you have a little bit of a response, you relapse quickly. IgG went to 10,000. Actually, it was over 10,000. I believe it was 11,000. And at that time, venetoclax was really not a drug we think of, but because the clinical trial that was done with venetoclax that included called Bellini trial was stopped early because patients didn't do very well. There was high mortality. So we ended up discussing that with the patient. I said to him, listen, you cannot even take full doses of treatment because your counts are bad. Let's try venetoclax as a single agent. And it took me 6 weeks to get insurance company to approve the drug because they didn't approve it. Eventually, he was not doing well, but he went on this treatment. And actually, to my surprise, he had the best response he ever seen since the diagnosis. And insurance company approved venetoclax for a year. After 1 year, the insurance company stopped the venetoclax. This time I fought with them for 8 weeks. Unfortunately, during this time, the patient response started progressing. Eventually, he got him venetoclax, but at that time, he was refractory to venetoclax. He had what's called escape, didn't respond, and progressed. And then 6 months ago, we decided to offer him the CAR T cell trial. And he ended up on a CAR T cell with an IgG close to 8,000, got lymphodepletion. I saw him last week. He is, again, continuing to respond. Every time I see him, his IgG level is down. His bone marrow has no plasma cells. PET scan is negative. 11-year journey for this young patient who is currently in his early 40s. I know that we all like the cases where a patient gets diagnosed, achieve a remission, stay in remission for 20 years. I'm happy for those patients. They have biologically fantastic disease that they respond and they don't see the treatment. But I did very little to those patients. But this is what we are doing as physicians, and this is what gives us satisfaction. This patient got married last week, and I was very happy for him. If he's on the call, we still have more treatments to give if you progress, which I hope will not happen, but we will see how far we can go. This is what keeps us going. I think Dr. Mikhail will agree. It's so funny, yesterday I saw this guy in my clinic, Thursday, and I saw another woman who is 75 years old. She was diagnosed 15 years ago, and she told me, I have seen my grandchildren finish high school, and that made my day. So really, as a community, I think Dr. Mikhail described it very well. As a community, we are obligated in our area to raise awareness about the disease. We need good standard of care. I am very pleased that the standard of care in multiple myeloma in our area is very high. Most of the physicians call us, ask a question. We learn to answer those questions. We give induction treatment in the community. We work very well with them. I always ask them to send me the difficult cases. I am happy to say that in our center, we have opened every clinical trial for every approved drug in multiple myeloma except melflufen. It just sneaked on me. I don't know how. And I think support throughout the myeloma journey. Trust. If you don't trust us, please find someone you trust. If you go to 3 different places and don't trust anybody, maybe you need to redefine your expectations of the physicians. And those patients usually don't do well when they start having trust issues with us. I think diversity needs to be explored. And I think building a family of support, this community we are talking about, I'm very proud that we have a great multiple myeloma support group, has been run in the last few years with Becky, who I know that some of you in the IMF started to know her. She's a wonderful resource for us, and patients always like to share their experiences. And I'm very proud to be part of this journey. I enjoy it more than patients can imagine, being part of their lives, and try to do as much as I can to help them. That's what I have to say, Joe. I hope I didn't go over time. I don't know.
No, Ashraf, that was just fantastic. Thank you. Heartfelt and intelligent. You know, I always say you want a doctor that has a brain, a big brain and a big heart. And honestly, Ashraf, you have both. And that's evident. I can see Bonnie agreeing with me too. And she's got pretty much firsthand experience